Get started. We are recording this. You notice something pop up in your field. Professor Schroeder was so kind to allow us to record so that alumni and parents and community members who weren't able to tune in because of work or family obligations or whatever reason it may be can enjoy this later. We do record most of our virtual programs, so you can find it on the virtual library that we have on the alumni and parent website. Go to cmc.edu/alumni or cmc.edu/parents, and you'll be able to click on the virtual library and review the incredible programming we've had over the last 3 months. A few things about Zoom. At the bottom, there is a chat feature and a participants feature. If you click on chat, the Zoom group chat will pop open to the right. You'll see people putting their names and their cities and states and class years or parent years. I encourage you to do the same if you haven't already. And then if you click the participant feature, that'll pop open to the right as well. And you'll see all the list of names of the people who are joining us today. There's also a place there to virtually raise your hand. And we're going to have about a 30-minute presentation from Professor Schroeder, and then we'll go into Q&A. I'll pull the Q&A questions from the chat, or you can virtually raise your hand and ask your question directly to Professor Schroeder. Finally, you can choose between speaker view and grid view. Top right, there's a button that says speaker or grid. If you pretty much just see me right now, that means you're on speaker view. And whenever someone speaks, it'll be that person who pops up in your screen. If you want to see a large number of people, click grid view, and you can see anywhere between 4, 8, and 30 or 40 people here that are on the call. My name is Evan Rudder. I'm the Assistant Vice President for Alumni and Parent Engagement at the college, CMC class of 2006, and we're thrilled to have all of you here on this Friday late morning in Claremont. First, a big thank you to all of you who supported CMC, both with your time, your talent, and your treasure over the last year. Our end of the year was June 30. We started a new year on July 1. This is obviously the new academic year, but also our new fiscal year. Over 4,000 alumni and 1,000 parents supported the college over the last year, and we can't do all that we do, including supporting our incredible students, without all of your help. So a big thank you from myself, but from the entire college, especially as we navigate these uncertain times. As many of you know, we unfortunately will be online in the fall semester, but I am happy to report that the college is working around the clock to ensure that our students are fully supported and that our faculty have everything they need to teach in virtually and be very engaging and supportive over the next semester. It's now my pleasure to turn the presentation over to Professor Andrew Schroeder. Professor Schroeder is an associate professor of philosophy at CMC and joined us in 2011. Professor Schroeder's research and teaching covers a range of topics in ethics, political philosophy, bioethics, the philosophy of disability, and the philosophy of science. Right now, his focus is on promoting work in what he calls the political philosophy of science, using concepts, tools, and methods drawn from political philosophy to shed light on the value-laden decisions scientists must make. And I must note that Professor Schroeder will be sharing his screen, so if your screen changes, that is why. Today's topic is the ethics of scientific modeling, a discussion of IHME's COVID-19 projections. Professor Schroeder, thank you for being here.
Thank you very much, Evan. This seems like a really wonderful program, and I'm thrilled that CMC has been able to do it. I just quickly skimmed the list of participants, and it's great to see a handful of names that I do recognize and a much larger list of names that I don't recognize. So I'm very happy to meet all of you today, especially in this time when it's really hard to meet new people. So I'm grateful that we've been able to, the CMC has been able to set something like this up. When I was asked to give a talk for this series, I spent some time looking at a lot of the prior talks that that other faculty and alumni and other people connected with the college had given. And I saw that a lot of them were on timely topics. And so I decided I would try to do the same. So let me go ahead and start sharing my screen right now. There we go. Okay. So a lot of my research, as Evan said, focuses on the philosophy of science and on the ethics of scientific research. And so one area in particular where I've done the most work concerns work in epidemiology and global health. So I've done a lot of research on the philosophy of those areas and ethical issues that arise in the course of work in epidemiology and global health. So what I figured I would do is use the next half hour or so to talk to you about some important issues that come up in scientific modeling. And I'm going to focus, as Evan said, in particular on the COVID-19 projection model developed by a research institute called the Institute for Health Metrics and Evaluation. And this projection model has been used, or I actually think misused, to justify a lot of really crucial policy decisions. So that's what I'm going to talk about for probably about half an hour. And then I'm really looking forward to your comments, your questions, your thoughts, your ideas. Okay. Let me begin by introducing you to a very important figure in global health. So this is Chris Murray, as you can see from his website right here. He is the director of IHME. Again, that's the Institute for Health Metrics and Evaluation, which is a research institute based at the University of Washington in Seattle. Now, Chris Murray and IHME are famous as being, well, IHME is the headquarters and Chris Murray is the lead investigator of the Global Burden of Disease study. The Global Burden of Disease study is a massive epidemiological research project, probably the biggest one that human beings have ever attempted. It began in the 90s at Harvard. It moved from Harvard to the World Health Organization and now has moved from the World Health Organization to the University of Washington, thanks to a $100-and-something million grant from the Bill and Melinda Gates Foundation. Now, what the Global Burden of Disease study tries to do is essentially to create a snapshot of global health and then to continually update that snapshot for each successive year in the future. So essentially, they go to different regions on the planet, countries, states, counties, cities, and they try to figure out the health status of the population there. At what age are people dying? What kinds of health problems are they dealing with? And so forth. And so a lot of the times when you see on the news discussions about changes in global life expectancy or an outbreak of tuberculosis or our progress in dealing with HIV and AIDS, a lot of the times the information that you're seeing is information that comes from the Global Burden of Disease study and Christopher Murray. Now, because the Global Burden of Disease study is such a crucial research program for a lot of work in global health, Murray and IHME have for a long time been very well known among epidemiologists, global health scholars, health policymakers, NGOs, things like that. But recently, Chris Murray has started to get a lot of attention, not just from other scholars and policymakers, but from the public. So here you can see Murray with Wolf Blitzer and Anderson Cooper and a whole bunch of other different people. Anderson Cooper a few times, I guess. And so the reason for that is that at the very start of the COVID-19 outbreak in the United States, and remember, it started in Washington, right near where IHME is based. At the very start of the COVID-19 outbreak, IHME decided to use their expertise in modeling infectious disease around the world to figure out if they could create a good model that would help us to understand potential paths for COVID-19 in the United States. Their initial goal in creating this model was to help hospitals figure out what resources they were going to need, how many ICU beds they would need, how many ventilators they would need, and so forth. Now, from the start, when their model was released in, I think, mid to late March, it got a lot of attention for the obvious reasons. First, because it was one of the first models in the US to deliver detailed predictions. Second, because their website is just really fancy and pretty. So if you go there right now, they have a lot of great data visualizations that are easy to use and pretty easy to interpret. And then third, of course, because it was coming from such a respected outfit. But the real turning point, the point at which the IHME model and Chris Murray became much more visible to the public, was here. So in late March and in early April, the White House began to use this model as one of, if not the main projection model that they were relying on. So here you can see a screenshot from a White House press conference where Dr. Birx is talking about possible paths for COVID-19 in the United States. And you can see, if you have a large monitor or your eyes are better than mine, that she is talking about the IHME model from Chris Murray. And so once the White House picked up on this model as an influential model, it started to get a lot of attention from other policymakers and from the public. And so from that point in late March forward, the IHME model has been one of, or perhaps the most cited COVID projection model in the US. Okay. So in a moment, I'm going to show you that model and tell you a few important things about it. But before I do that, let me make a possibly important disclosure. So if you were to go to the IHME website and dig around in deep dark corners where nobody ever looks, you would find an entry for me on that website. And that is because before I came to CMC, while I was doing a postdoc, I spent, I think it was about 5 months as a visiting scholar at IHME. My goal in doing so was to get a fuller appreciation for the way scientific research actually works in the real world, and in particular for the way the global burden of disease study works in the real world. In my further research on science, I wanted to make sure that I was operating from an accurate picture of what happens. And so I spent a few months in Seattle, first just trying to understand what the global burden of disease study was and how the research went. And then I spent a few months basically shadowing epidemiologists, statisticians, mathematicians, modelers, other people there, and probably asking them all sorts of annoying questions just to really get a sense of what was going on. And so as a result of my time there, I did get to know Chris Murray fairly well. That relationship has continued into the future. We recently co-authored an article together that appeared in a book that we co-edited together. And so I mention all of this to you for 2 reasons. First of all, I think that perhaps I have some insight into the way things operate at IHME and into the way Chris Murray thinks about things. And then second, and probably much more importantly, you can take everything I'm going to say with a grain of salt because I'm not an entirely disinterested observer when it comes to IHME and in particular criticisms that they have received. So with that caveat out of the way, let's actually take a look at the model that they developed and that the White House publicized. So before I show you some data or some outputs from the model, let me say 2 important things in case you're not familiar with their projection model. So the first thing to know is that their projection model, like just about every COVID-19 projection model out there, has changed a lot since late March and early April. They've been continually updating it, not just as new data come in, but also as we learn more about what influences and what doesn't influence the spread of COVID-19. So if you look at their early models from March and April, they don't account for wearing masks at all, because back then in the United States, the view seemed to be that mask use was not an important factor in dealing with the spread of COVID. We now know, of course, that that was absolutely wrong. And so if you go to their website today, you will see that their new models do incorporate mask wearing and try to model differences in mask wearing between different regions of the United States. But the first point is just that the model has changed a huge amount over time. The second thing that it's important to know is that the model has a ton of different outputs. As I mentioned, originally the main outputs were going to be things like hospitalizations, ICU beds required, ventilators required, and so forth. But of course, they also predicted things like the number of deaths they anticipated from COVID-19. So in the talk, the rest of the presentation, I am going to focus on 2 things. First, I am going to focus only on their projection of total deaths, not the other outputs of the model. That's because in a way, deaths are the easiest thing to understand. And second, their death projections are what has received the most public attention. And then second, as you can see from the heading on this slide, I'm going to be focusing on a very early version of the model from April 8th, and I'm not going to look at their much more recent and much more sophisticated models. The reason is that this April 8th is right around the time that the White House and a lot of other government agencies were touting this model and using it to justify policy decisions. And so I think if we're interested in how those policy decisions were made, it's valuable for us to look at the model as it was back then, not as it is today. So with those 2 clarifications, here is what the model showed as of April 8th. Okay, so if you look at this model, look at the graph, what it's telling you is that as of April 7th, which is obviously the last day they had data from on April 8th, there had been 12,704 COVID-related deaths in the United States. And if you look at that dotted line, which was their most likely path forward, you can see that it climbed steeply, which means they were projecting a continuing increase in the number of deaths per day through probably about mid to late April. Then you see the curve begins to bend, it begins to flatten, which means their model projected that the number of deaths was going to slow down beginning in late April. By mid-May, it's almost flat, and by the end of May, the line is perfectly flat, meaning that this model was projecting that by the end of May, by the beginning of June, we were not going to be seeing a significant number of additional COVID-19 deaths. The epidemic was basically going to have run its course, and as you can see from the big boldface thing at the top of the chart, they expected that the final tally by about June 1st was going to be around 60,000 deaths resulting from COVID. Okay. So that is what their model projected as of April 8th. Now, the thing about that model from the perspective of today is how poorly it matches the actual trajectory of COVID in the United States. As you all know, we have 150,000 deaths right now, and that number is climbing fast. But you don't even need to just evaluate it from the perspective of today. Even by late April, just a few weeks after this model was produced, it was very clear that the country was going to go well past 60,000 deaths. And so, unsurprisingly, given that this model had been prominently touted by the White House and others, there were a rash of articles that came out in late April and early May criticizing, in some cases very severely so, this model for having really made some horrible predictions. So here are some examples of those articles. One from Vox.com. This coronavirus model, the one that I've been talking about, keeps being wrong. Why are we still listening to it? And then at the bottom of the screen, an article from Politico, how overly optimistic modeling distorted Trump team's coronavirus response. And you can see that they, below that, talk about the model from the respected University of Washington site. That's the one that you just looked at. And then even other modelers piled on and criticized what had happened at IHME. So what you see in this graph in the top right corner is a screenshot that I took from another modeler's modeling outfit's website. And it shows in gold the actual trajectory of COVID-related deaths in the United States. The dotted blue line is the projection that their model had given, and the dotted red line is the projection that the IHME model had given. So you can see the point of this graph is to show that their blue line does a pretty good job of tracking that gold line. They did a good job of predicting how many COVID-related deaths we were going to see, whereas the IHME model is consistently below that gold line. It's consistently underestimating the number of deaths that the United States was seeing from COVID. Okay, so the criticism in all of these articles and graphs seems really straightforward. The IHME model predicted that we were only going to see 60,000 deaths. We are currently at 150,000 deaths and climbing. Even by the end of April, we were at about 60,000 deaths. Therefore, the IHME model, it wasn't just wrong. It was very, very, very wrong. Okay. So I think that criticism, it seems really straightforward. But let me try to convince you that things are a lot more complicated than this simple criticism would suggest. I actually think that, as it's stated here, this is not a valid criticism of the model because this first claim is a lot slipperier, a lot trickier than it might initially appear to be. Okay, so let me explain why I think we need to zoom in on this first claim and understand it before we can evaluate this criticism. Okay, so here's that the model that I showed you earlier. Now, as I mentioned, this was only one of many graphs that appeared on IHME's COVID projections website. They had graphs about hospital usage, about ICU beds, about ventilators, and so forth. So this was, I think, the 5th or the 7th graph of a long list of graphs. Now, what I perhaps unfairly omitted in showing you simply this graph was the heading that was at the top of the web page. So let me put that heading up. Okay. So you see that what they're talking about are projected COVID-19 deaths, assuming social distancing through May 2020. That's obviously a very important phrase. Now you might wonder, what is it that they meant when they talked about full social distancing through May 2020? Well, fortunately, they have an FAQ linked right at the top of the page, and so I clicked on that for you. And so this, I believe, was the 2nd or the 3rd FAQ on their website. How are social distancing measures used in the model? And so I'm going to read the highlighted passage, which is what we need to focus on. It says, the model includes the effects of social distancing measures implemented at essentially the state level. we classified distancing measures using the New Zealand government alert system level 4, and then assumed that locations that have instituted fewer than 3 of these measures will enact the remaining measures within 7 days. Now, you again might wonder, what is this New Zealand government alert system level 4? Well, here's what happens if you click on that. Alert system level 4 in New Zealand requires a full stay-at-home order, all schools closed, all non-essential businesses closed, all travel severely limited, and then a few other hospital-related things that are less relevant for our purposes. Okay. So by paying attention to the heading and following these links, what it looks like we have here is a model that incorporates the assumption that the entire United States is going to have extremely strict social distancing requirements in place from mid-April, 1 week after the model was released, through the end of May. Right? And indeed, the FAQ, if you look at the last sentence, they emphasize that this model says nothing about when or whether social distancing measures could be lifted. It simply assumes that we are going to have very strict social distancing measures in place through the end of May. Okay? So this should feel to you like a pretty weird assumption for someone to make in early April, right? What we have is a model that tells us that about 60,000 people are going to die. But the reason it gave us a number that low is because it makes this assumption that we're going to have very strict long-term social distancing. Now, anyone paying attention in early April had to know that that was not a realistic assumption, right? Places like Florida and Georgia never implemented everything on New Zealand's list. And even places like California that were much more proactive, we never reached the strictness of New Zealand. There was never severe travel limitations within the state of California. I could get in my car any day this spring and drive to Nevada or drive to Northern California. We just didn't have that. And the measures that we did have, things like non-essential business closures, did not last anywhere near until the end of May. Some non-essential businesses started opening up, I believe, in mid-April or late April, okay? So we have this model that incorporates an assumption that the entire US was going to be on a very strict lockdown for 2 months, for 2.5 months, that simply didn't plausibly mirror what reality was going to look like. So what's happening? Why did we have a model that incorporated such a crazy assumption? Well, one possibility, and this is the possibility that most people who commented on the model and noted the assumption that it was making, this is the assumption they seem to endorse, or the possibility they seem to endorse, is that, to put it bluntly, Chris Murray is pretty stupid and politically naive. He never realized that the US just wasn't going to implement a full Wuhan-style lockdown that was going to last for 2 months or so. And so he was politically naive, he didn't realize that, and so he incorporated this horribly unrealistic assumption into his model. Okay, so that's the possibility that most people seem to latch onto. But here's the thing. I know Chris Murray. Chris Murray is not stupid. He's definitely not politically naive, right? You don't go from Harvard to the World Health Organization to $100 and something million grants from Bill Gates by being stupid and politically naive. So I don't think this possibility is a good explanation for what's happening. But if that's not happening, then what is going on? What is a better interpretation of why they incorporated such an unrealistic assumption into their model? Well, I think it's this. I think that what we have here is a model that was never supposed to predict what will happen in the US. What it was supposed to do was to project what would happen if we had implemented and maintained a lockdown, right? So it had a different job, not trying to tell us what will happen, but trying to predict what would happen if we did some particular thing. Now, you see the asterisk there, because things live forever on the internet and you never know who's going to see these things. Let me just add a caveat at the bottom. I do not know whether this is what Chris Murray and IHME actually had in mind. I haven't talked to anybody there since the model came out. And if you look at the relevant public statements on this, they've been confusing, a point that I'll return to a little bit later. Nevertheless, I do suspect that something like this is what they did have in mind. And in any case, I think it's what they should have had in mind, even if it wasn't what they were explicitly thinking. But I do suspect it's what they were thinking. Okay, so let's assume that my suspicion is correct, and that what we have is that a model that is not trying to predict what will happen, but it's trying to project what would happen if we had taken certain actions, implemented and maintained a lockdown. Well, if that's right, then we need to think about the model very differently. So for one, it means that we can't assess its accuracy by comparing it against what actually happened. The model was telling us what would have happened if we had implemented strict distancing measures. And so the fact that right now we have 150,000 deaths versus the 60,000 that the model projected is not in any way a criticism of the model, because the model was telling us what would have happened in this fictional alternative reality that we didn't inhabit. And so of course, it's not going to line up with what actually happened since we didn't implement those strict measures. That's one thing. Second thing, we can't sensibly use this model to decide when, how, or whether to relax distancing measures, right? All the model is projecting is what will happen if we do implement distancing measures. It says nothing about what's going to happen if we don't implement those distancing measures. So we can't sensibly use it to make those sorts of decisions. So what can the model be used for? Well, it can be used to justify implementing strict distancing measures. If, for example, we think that we're on a much worse path than 60,000 deaths, and we think that this is an accurate model, then we could use the model to decide, well, we better implement strict distancing measures because we would much rather be on the path that leads to 60,000 deaths and the epidemic petering out by late May. So it could be used to justify implementing distancing measures. It could also be used to help us prepare for the consequences of implementing distancing measures, to figure out how many ventilators or hospital beds we're going to need. And it probably also could be used to, in a way, give us a best case scenario. Given that strict social distancing measures seem pretty clearly to be the best way that we have of preventing COVID-related deaths or spreading the slow of COVID, what this model does, since it assumes strict distancing measures, is it gives us a best case scenario. It tells us what's going to happen if we kind of do everything right. Okay, so that's what the model can and can't be used for. Now, after hearing that, I think you might wonder, well, okay, I understand that, but why did IHME choose to create this sort of a model instead of trying to actually predict what was going to happen? Wouldn't it have been more useful for them to use their expertise and their resources to try to actually predict how the epidemic was going to unfold, not to tell us how it would have unfolded in some imaginary alternative world? So for some purposes, yes, a true predictive model, one that actually tried to guess how the outbreak was going to unfold, would have been more useful. So if, for example, you're trying to figure out how many ventilators the United States needs, what you want is the best prediction we have of how the virus is actually going to unfold, how the epidemic is actually going to unfold. You don't want to know how it would unfold in some fictional reality. Similarly, if you're the head of state of Canada, you're trying to decide when you're going to open your borders and let Americans back into your country again, what you want is a prediction of how things are likely to unfold, the best guess at the actual course of the epidemic, so you can decide when it's safe to open your borders again. So for those purposes, yes, a true predictive model would be a much more useful model. But for a lot of other purposes, and especially for the purpose of deciding on policies designed to affect the spread of COVID, you actually don't want a true predictive model. A true predictive model is not useful for those purposes. Here's why. If we have some policy decision, say a decision about social distancing policies, or a decision about mask requirements, or a decision about test and trace programs, if you have some policy decision that is expected to affect the spread of COVID, then any true predictive model is going to need to make a prediction about what policy is going to be adopted. So for example, mask mandates greatly slow the spread of COVID. We know that now. So if I am trying to make a true predictive model to guess how things are going to unfold in the future, I'm going to need to make a prediction about whether my governor is going to impose a mask mandate. Because if she is going to impose a mask mandate, I need to lower my prediction. If she isn't going to impose a mask mandate, I need to inflate my prediction. I need to make a significantly higher prediction of the number of deaths that are going to result. Okay. So the point is, is any true predictive model has to build in assumptions about what distancing policies, what masking policies, what testing policies a governor or government agency is going to implement. Okay. But now suppose that I'm a governor and I'm trying to decide whether to implement strict distancing policies. A model that has already predicted what decision I'm going to make about those distancing policies is not a great tool to help me make that decision, right? That model has already decided what it thinks I'm going to do. If I'm trying to figure out whether to implement distancing policies, what I need is a model that projects outcomes under each possibility. Right? A model that tells me on the one hand what will happen if I do implement distancing policies, and then on the other hand, a model that tells me what will happen if I don't implement distancing policies, okay? But models like that are not true predictive models. They're not trying to figure out what will happen. They're trying to tell a policymaker what would happen if certain policies are implemented or are not implemented. In other words, they're doing the same kind of thing that the IHME model is doing. Okay? So the point here is that although a true predictive model is valuable and important for certain policy decisions, there are a lot of other policy decisions where true predictive models are not useful. And that crucially includes the decisions that were being made in early April, when this model was released, about what distancing requirements were going to be introduced or whether distancing requirements were going to be introduced. For those purposes, what you want is a model like the IHME model that projects outcomes under different scenarios. Okay, so for the reasons that I have just described, I don't think that the main criticisms that have been leveled at the IHME model are good criticisms. Yes, it's true, the IHME projections did not match up with reality, but that's not a criticism of them because they were never trying to predict reality. What they were trying to do was to fill a different and a crucially important role. So I think those criticisms fail. Nevertheless, I think there are still problems here. Things still went wrong. And so I'm going to end the talk by talking a little bit about some failures that I do think went on here. So first of all, the White House and other government agencies at least claimed to have relied on the IHME model in their decision-making process. Now, of course, I have no idea whether they actually relied on this model in their decision-making process or whether they just said they did. But if they actually relied on this model in their decision-making process, then that was a serious misuse of the model. And I think that people at places like the White House should have known better. They should have known that it was a misuse of the model, right? As we saw, the early IHME model, all it did is offered projections for what would have happened under strict long-term distancing programs. It made no projections at all about what would happen under moderate or weak distancing requirements. However, after citing this model, the White House issued guidelines that fell far short of the guidelines that the model had considered. So I've put up here the New Zealand level 4 guidelines, and then the White House's 30 days to slow the spread guidelines, which were issued at about this time. And you can see that there is no severe travel limitation in the White House guidelines. They don't require that all non-essential businesses, or don't even request that all non-essential businesses be closed, and so forth. So these are guidelines that are not nearly as strict as what the model contemplates. And they're also not in place for as long as the model contemplates. This was a 30 days to slow the spread program. The model was projecting that these were going to be in place for at least 60 days or for the following 60 days. So essentially what happened is that the White House cited a model to justify implementing policies that the model said nothing about. That's obviously a misuse of that model. Okay, so that I think is one failure, a misuse of the model. But I don't think that's the only failure, right? I think there's also a failure on the part of IHME. So although their model was misused, I think IHME could have taken more steps to prevent it from being misused. In fairness to IHME, they were explicit about how their model worked. I showed you that right at the top of the web page, they clarified that their model was making this assumption, and there were links right there that gave you detailed descriptions of how it worked. And they explicitly said that the model could not be used to figure out when or whether to relax social distancing guidelines. So they were explicit about this limit of their model. However, given the policy discussions that were in the air in April, when it was very clear that many parts of the United States were resistant to any social distancing guidelines, and other parts of the United States, like California, that even if we had implemented them, we were preparing to relax them much sooner than the model contemplated. Given that those discussions were in the air, and given the potentially catastrophic consequences of failing to implement strict distancing measures, I think IHME should have been more proactive to guard against this sort of misuse of their model. So here again is the model, and as you can see, it does have that explicit statement at the top, but I think they should have done something more like this. Put a box like this on every single graph throughout the page to make it much harder for people to misunderstand or to misuse their data. To clarify that all this model is projecting is a best case scenario where strict distancing is in place through the end of May, and you can't use it to justify decisions to do other things. Okay, so I've gone a little bit longer than I wanted to, so let me end with a few takeaways, and then I'm really eager to hear your thoughts and questions. So let me try to wrap things up. First point, when looking at any scientific model, not just COVID, but any scientific model, it is extremely important to understand what that model is suited for and what that model isn't suited for. There are a lot of great scientific models that are very useful for making a certain very specific type of decision, and that are utterly useless for making other apparently similar types of decisions. It's really important to understand the limits of scientific models. Second, more specifically, true predictive models and projection models like the IHME model are really easy to confuse. And they're really easy to confuse because the outputs of the model look identical. A true predictive model about the number of COVID-19 deaths in the United States is going to give you a bunch of dates, and then it's going to associate a bunch of deaths with each of those dates. A projection model is going to do exactly the same thing. Its output is going to be a bunch of dates and then a bunch of deaths associated with each of those dates. So these models, because their outputs look identical, they are very, very easy to confuse. But as we saw, although they are both useful models and we want to have both of them, they are typically not useful for the same purposes. The kinds of decisions that predictive models are helpful for, projection models are not helpful for. And vice versa. The kind of decisions that projection models are good for, predictive models are typically not very useful for. Specifically, we saw that the IHME model projected outcomes if strict social distancing was implemented, but it was at least apparently used to justify decisions to relax distancing requirements or to impose less strict distancing requirements, things that the model said nothing about. And then finally, if that April 8th IHME model was accurate, and again, we have no direct way of telling whether it was accurate because it made predictions about a world that we're never going to see. But if it was accurate, the cost of this kind of a mistake, the cost of not implementing those strict distancing requirements was 90,000 lives and counting. So thanks everybody very much. I'm really eager to hear your questions. If there's not time for anything, I'd also be really excited to have an email from you. So you can see my address there, or you can grab it off of the CMC website. Thanks.
Thank you, Professor Schroeder. We have a number of questions that came in through the chat. We also do allow people to virtually raise their hand and be called upon to ask Professor Schroeder any questions directly. So think about a question, think about if you want to put it in the chat or if you want to virtually raise your hand. The first question that I have is whether you think the US should adopt the New Zealand lockdown protocol for 2 months. While painful medicine, would it put COVID behind us? Is it time to bite the bullet?
So the first thing I would say is that if we wanted to know whether it would put COVID behind us, then what we want is an updated version of essentially the same model right here, right? And so I'm not an epidemiologist. I don't know exactly how that model would turn out, but that would be the kind of model that could answer your question well. And I'm sure if you go to the IHME website, they may well have that prediction right there. But for the moment, let's assume that it would. If it would, I mean, then I think we do have to do a balancing because of course there are lots of costs of that lockdown. As you pointed out, it's painful medicine. Myself, I think yes, I think that we should. However, I think that that's a further question that we would want to talk about, and we would want to be clear about what the costs of that sort of a policy are. And now that we know more things about wearing masks, it's at least possible that we could get similar results with somewhat less strict requirements. So for example, as someone who lives in Los Angeles, going to the beach appears to be a very low risk activity if you're not around lots of other people. And so if we have socially distanced beaches, that doesn't seem to be a very high risk activity. So it's at least possible that we could get similar results with somewhat less strict procedures. But again, if you want to know that, you want models of the sort that IHME released. So the quick answer is that, yeah, I think probably, but that's another conversation.
Jeff Mason, go ahead and ask your question.
Yeah, this was fascinating. Thank you for giving us a lecture. This is sort of a general question about projection models and prediction models. And, you know, I question the value of having one without the other. In other words, when they were doing this projection model that said, you know, if strict distancing is imposed, this is what we would expect. Isn't it difficult to interpret that without the other kind of model being done at the same time? And shouldn't that have been, isn't that a criticism of, you know, what they did?
I fully agree with you that these models can often work well in tandem, or even if you don't have a true prediction model, at least multiple projections under different scenarios would have been a much more useful thing to have. So the good news is that if you go to the IHME website today, they have projections under multiple scenarios, which gives you more of what you're suggesting we need.
Yeah.
I would say two other specific things. First of all, and this relates to details about the way they created their model was actually not a model that could be adapted to become a true predictive model. It was based on the experience in Wuhan and later in other regions. And so it was grounded in data that came from places that had implemented strict lockdowns. So in fact, if they had wanted to do a prediction, they would have needed to create a whole new model. I think or hope what they would have said is, great, use our model, pull in another model from another set of researchers who are making true predictions, and then we can get the kind of comparison that you're asking for. But yes, I absolutely agree. They work well in tandem.
Thank you. Next question. Do you think the model can be regionalized so that, for example, if you had a California model or an LA County model, you could use it to determine rollback of lockdown or implementation of different phases of opening up?
The type of model, yes, can be used for that purpose. And if you go to the IHME website right now, you can get it at a state level. They don't have it at a smaller scale than that. So if you wanted to know about Los Angeles County or something like that, they don't have that, but they have it, at the state level. So yeah, you can use a model for that. Now, when you mentioned rolling back lockdowns, again, you need to be very careful because as the April 8th model was implemented, it said nothing about rolling stuff back. Their more recent models do give outcomes under different scenarios that include rolling back guidelines. So yeah, if you want to see their current predictions, you can go to their website right now, and it's right there, state by state.
How could or should we judge the accuracy of the model now, given that it's not predictive and can't be judged against what actually happened?
So I think this is a really hard question. We can't do the kind of classic science experiment that you would want to do, where you just see what happens and then see if your prediction matches what happens, because it was a prediction about something that we are never, ever going to see. So assessing the accuracy of a projection model is extremely difficult. It may be impossible. The one thing I would say that gives us reason to think that whether or not it was accurate, it was at least kind of close, is if you look at the experience of other places that did implement strict lockdowns, and I'm not just talking about Wuhan and New Zealand, but also, continental Europe, places like that, places like Italy, places like Spain that had much stricter lockdowns than we did. You can see that their death rate, their death toll, came down much, much more quickly than the United States has. And so that makes me think that their original projection, it wasn't crazy. Whether it was accurate or not, I have no way of telling, and I don't think we have any way of telling. But it wasn't crazy. But the only way to really know if it was accurate would have been if we had implemented those measures and then see if it ended up turning out the way they projected.
Thank you. What is the responsibility, if any, of the quote unquote experts within the government who use the IHME model?
So this one is tricky. I think that typically, experts should bear a lot of responsibility for the use and misuse of scientific information, because it's unreasonable to expect that policymakers who have to make decisions about a huge range of different subjects, it's unreasonable to expect them to be experts in every scientific field that might be relevant to the decisions that they need to make. And so I think it's important that they lean on experts, and therefore experts bear a lot of responsibility. Now, in this case, though, I think the blame is a little bit more broadly spread. And that's because, as I showed you, look, I explained to you in 15 minutes the reasons that this was clearly a misinterpretation of the model. I didn't need to go into some kind of very complex analysis. In this case, I think it was fairly straightforward. And so I think it's quite reasonable to expect that not just the experts, not just the scientists, the public health scholars, but also some policymakers should have been able to spot this on their own, at least with a little bit of guidance from aides or whoever.
What responsibility do you believe academics and modelers like IHME have when their work is used to make policy decisions, perhaps especially in political climates like today, but also in general?
So I don't have a really great answer to this other than to say, I mean, as I mentioned at the end of the talk, I think that what IHME did was not adequate from an ethical perspective, because I didn't watch all of Chris Murray's interviews because I don't usually watch TV, I just read my news. But if you look at his interviews on CNN, I watch him the videos, and he doesn't, start making these complaints that I'm suggesting he probably should have made. And he had the microphone to do it. He was on Anderson Cooper, right? He could have just said right there, I want everybody to understand this is not the kind of thing that my model can be used to justify. And so I think they do have a significant responsibility to get out there if they're able to, and point out when people are misusing their stuff. Now, that said, for all I know, behind the scenes, he was doing that. I know that people at IHME were in contact, personal contact, with Birx and Fauci and probably other people from the White House and state governments. And so maybe behind the scenes, they were jumping up and down saying, you can't use our model for this. You can't use our model for this. And if they were, then maybe that's enough. I don't know what to say about that. But I guess I think they do have more responsibility than they showed in this situation.
Thank you. Alan Delsman, go ahead and unmute and ask your question.
Yeah, it's more of a comment. I work in finance, and in leverage finance, it's interesting that we have to do 3 different projections. We take a base case from the company, we do our own projection, and then we have to do a stress test, and that's dictated by the Federal Reserve Bank. So, and we have as many problems as IHME might have in doing projections like that. But it's just interesting in those cases, which is not dealing with people's lives. The government does require 3 different projections. They wouldn't just take one projection.
Yeah, you know that.
All right, next question. Alan, unmute. Perfect. Do you feel that IHME made any other visualization mistakes on the graph, in your opinion?
So one thing that I didn't talk about that some other people have commented on, and I think is worth thinking more about, is, so I don't, let me see if I can call it up real quick. Let's see, screen share. Here we go. So if you look at the graph right here, you can see that in addition to the dotted line, they have this shaded area. And as the bottom notes, the shaded area indicate the uncertainty around their estimates, right? And so one really striking thing is that they didn't just say 60,000 deaths. If you look at those shaded areas, their estimate was actually that the death toll was likely to end between about 32,000 and 127,000, right? That's a huge, huge band of uncertainty. And they did, again, in fairness, note this in a number of TV interviews, commenting that you shouldn't just take their single 60,000 number to be the important one. There's this very, very large range of uncertainty. Nevertheless, when you look at these kinds of articles that were criticizing them, when you look at the way their model was reported on by journalists, by political figures and things like that, people tended to latch on to that single estimate, the 60,000 number, and not acknowledge the fact that there was a huge amount of uncertainty around that estimate. And so I think one really challenging thing for scientists to do is to figure out how to communicate not just their best guess at an outcome, but how confident they are in that guess and what the uncertainty around that guess is. And so I guess in this case, it seems like, they showed it on the graph, the shaded regions are there, but they probably could have done a better job of emphasizing that this was a very uncertain prediction, because in early April, there was very little we knew about COVID-19. And so it's not surprising that they had this. But yeah, I think they could have done a better job of emphasizing that. In fairness to them, though, it's a really challenging thing to do.
Do you feel that the death count is accurate because anyone who dies in the US and tests positive for COVID is counting as having died of COVID, even if there is a co-mortality cause like stroke, heart attack, or cancer? Does it make sense to count COVID deaths in this manner because it has a bias toward an overcount?
When I was asked by Jenna to give this talk, I waffled back and forth between two different talks that I might have given. And the one is the one that you saw, and I'm pleased with my choice. But the other talk is exactly what your question is about. I think you're exactly right to say that this is a really complicated question. What counts as a COVID-19 death? Okay. And so you point to one respect in which we may have an overcount, because we chalk everything up to COVID if the person is COVID positive when they die, even though in many cases it may have been because they were immunocompromised for these other reasons, and it might seem more natural to then attribute that death to the other cause. But there's also all sorts of reasons to expect that we may have an undercount here. Again, what about the many deaths among COVID negative people, but where they wouldn't have died if we didn't have an outbreak? So think about the person who has a heart attack in New York City at the peak of the outbreak, and the ambulance either can't get to them in time because it's busy with other patients, or they don't call the hospital because they're too scared. They don't think it's a heart attack, and so they don't go in to get checked out because they're too scared that if they go to the hospital, they're going to contract COVID, right? And that person maybe dies. They're not going to be chalked up as a COVID death because they weren't COVID positive. But in a certain respect, the virus is responsible for their death because they'd still be alive today if we hadn't had this outbreak. And so I think there are all sorts of factors in both directions that might lead you to think that the current number is an undercount or that the current number is an overcount. And then when you step back, it turns out that philosophers and scientists have written a huge amount about the notion of causation. And I think the best work in the area suggests that the question, what counts as a COVID-19 death, it doesn't have a single answer. When we talk about causes in the real world, we pull out things not because merely of their scientific status, their status as features of the natural world, but because of what we're interested in. So imagine that someone throws a match on a dry haystack and it catches on fire, right? If someone asked you, what was the cause of the fire, you might say the match, or you might say the person who threw the match. But you could just as well have said the cause of the fire was the presence of oxygen, because if there wasn't any oxygen, there wouldn't have been a fire. Or you could very well say that the cause of the fire was that it was the haystack wasn't wet, because if it had been raining, maybe there wouldn't have been a fire. So it could have been the lack of rain. And from a kind of philosophical perspective, from a scientific perspective, there's no reason to pick out the match instead of the lack of rain or the presence of oxygen. So it turns out when we assign outcomes to causes, we do so based on what our interests are as observers. And that means that figuring out what counts as a COVID death is even more complicated because we can't just stick to the science. We also need to step back and say, okay, well, should we count the person who had comorbidities but was COVID positive when she died, or should we attribute that to this other cause? Should we count the heart attack victim who didn't go to the hospital because he was too worried about contracting COVID or because all the ambulances were busy with other patients? So really complicated question. And so there's the tip of the iceberg.
A year ago, CMC announced that the college needed to invest in our own science program. I wasn't convinced at the time that was appropriate. Since COVID, I'm more than ever convinced that our students, especially those majoring in the humanities and social sciences, need scientific fluency. You're a philosophy professor discussing science. What are your thoughts on the future of science at colleges and universities, including CMC?
So selfishly, I was very excited about the idea that CMC might be doing a lot of hiring when it came to science and creating a new department, especially the possibility for creating these kinds of interdisciplinary collaborations. And so, because I mean, as you mentioned, I'm a philosophy professor, but science is crucial to my work, and in order to do my work well, I need to do it in dialogue with scientists. That's, again, why I went to IHME in the first place, because this wasn't stuff I could do on my own. So I guess I don't have a very interesting answer to your question, except to agree with everything that you said. I think that science fluency is important, not just for scientists, but for everybody. And I think that there are a lot of really valuable connections between science and philosophy, or science and literature, or science and history, that can best be explored by bringing those fields into dialogue with one another. And so I guess I would hope that the future of science education involves everybody, as we already do with general education requirements, but also tries to bring those fields into conversation with one another, because it can be really valuable.
Last question comes from Jordan. What justification do you believe policymakers have to prevent individuals who willingly risk their lives by not social distancing from, say, operating their business with other people who also choose to not socially distance, assuming people who do choose to social distance aren't directly impacted?
So I think the problem, or the challenge that your question raises, is the last thing. So you said, assuming people who do choose to socially distance are not affected. It's very hard to create environments where that if statement gets satisfied, right? Because all of us are gonna somewhat involuntarily come into contact with some other people. In order to survive, we need to get food somehow, whether that's through a trip to the grocery store or through a delivery from Amazon or Instacart or wherever. And a lot of us have to go to other places to make money, to go to work or something like that. And further, if the outbreak stays at a high level, then parts of the economy, like schools, just have to be shut down, right? Unless, I suppose, we could try to create one set of schools for people who want to socially distance and another set for people who don't. We don't have the infrastructure to do that. And so, in fact, if we have a group of people who have decided not to socially distance because they're willing to take those risks, their actions are going to affect other people. Now, I don't think that ends the conversation about what we should do, but it just means that we can't create this perhaps ideal situation where we kind of let everybody make their own decisions and bear their own risks, because the decisions that other people make will impact my life in all sorts of ways, just like the decisions that I make are going to impact their lives in all sorts of ways.
Thank you very much, Professor Schroeder, for this wonderful talk. We really appreciate it. Be safe and enjoy your semester ahead. For all of you joining us, we hope you join us next week and for future programming. On Wednesday, we have some of the stars and the director of the Netflix documentary Cue Ball, which is about some Stags baseball players who gathered some teams and created a program to play prisoners in San Quentin. Hope you review Cue Ball and join us on Wednesday. Dr. Schroeder, thanks so much. Everybody, I'm going to unmute, say hello, say goodbye. Have a great day.
Thank you, Professor. Have a great day.
Thank you so much. Really great.
Thank you.
Thanks, everyone.